We are fortunate here in our community to actually have a breast center of excellence. So the breast center at Stanford Valley Care is an actually accredited breast center of excellence. From diagnosis, which is the breast imaging center, which is also nationally accredited, all the way to therapeutics, surgery, chemotherapy, radiation, and what comes after that. I think we really pride ourselves in taking care of the whole patient rather than just their breast or just their tumor. Our wellness and survivorship program, we have representatives from there, our lymphedema program. All of that is meant to get a patient who is afflicted with breast cancer not only get treated, but actually get back to life as they knew life before all of this started. So we are proud of that program. So as we get started with tonight's speakers, I'm going to actually introduce Dr. Ruby Cheng, who's going to then introduce Dr. Wendi Martini. Dr. Ruby Cheng is a board-certified radiologist who currently works at Bay Imaging Consultants Medical Group. She's the medical director of the Diagnostic Imaging and co-chair of the Breast Steering Committee here at Stanford Valley Care. She had her fellowship training at Stanford University Medical Center. She was co-resident at Columbia Presbyterian Medical Center, and she received her medical degree at New Jersey Medical School in Newark, New Jersey. We are very fortunate to have her with us. Ruby, come on up.
Good evening. Thank you for coming. This is really exciting to see everybody here. Rishi is very complimentary in his introduction. I certainly don't feel deserving of all that. It is with great honor and pride that I feel very lucky to have Dr. Wendi Martini here to give you a great talk this evening. She is Professor in Chief of Breast Imaging at Stanford. Previous to that, she did her fellowship in breast imaging at University of Washington Medicine in Seattle. She is a world-renowned expert on breast imaging, published many countless articles and cited by thousands of other scientists and doctors in their articles that they want to write. Her emphasis is on imaging of breast cancer, characterization of breast cancer, and she's specifically interested in MRI. So we're really lucky to have her here, Dr. Wendi Martini.
Great. Well, good evening, everyone. It is such a pleasure to be here. I really thank the organizers for the invitation and of course, the sponsors and you, the attendees, for your time. Obviously, the venue is lovely, so thank you for that, and the evening is lovely as well. On behalf of Stanford Radiology, I want to say how much we look forward to providing care, and of course, in my case, particularly breast care, to the community. It is so incredibly important, and it's an honor that we are able to participate that. We'll start having some Stanford Radiology presence here in the next few months. And I think we're really establishing a great team of individuals who will participate, that including breast care. And of course, we're going to build, we are so lucky, we're going to build on the excellent care that you're already getting from Dr. Cheng and colleagues, and also continue to work with Denise Estrada and the team of staff at the various Valley Care facilities. So we feel very lucky in terms of these precedents and partnerships and collaboration, so thank you. And then I will say on a personal note, I actually grew up, born and raised just north of here, so I feel this is sort of a homecoming to be back on the east side of the Bay, albeit temporarily. So I'm going to talk to you this evening about some new tools and techniques that we have in breast imaging that we really think can and will improve patient care. And I'm going to start by just providing the context here. What are some of the key goals that we have for breast imaging? Now, this is not a complete list, but of course, some of our key goals in using our breast imaging methods are to find breast cancer, and ideally, we'd like to find that early through screening when it is the most treatable for our colleagues, as Dr. Sledge here. Importantly, though, when we are attempting to detect cancer, excluding breast cancer is equally important, right? We really want to minimize false positives, and I'll talk about one of the techniques that we have now that helps us with that. When cancer is present, one of the things that we want to do is characterize it. We want to determine what is the extent or the amount of tissue that it takes up, both locally in the breast and regionally, potentially in the lymph nodes. And then, of course, we provide in breast imaging image-guided procedures. These are really the standard of care for how findings in the breast that warrant biopsy are initially diagnosed. The good news is when we think about all the biopsies that we do in the breast, about 2/3 of them are actually benign and match the imaging appearance, and those women, thankfully, do not need to have any further surgery, for example. Conversely, about 1/3 of the biopsies that we do will actually be cancer, and that provides incredibly information to have that just done by a small biopsy through the skin, so that we know and you know a lot more options for the management, including by our surgical colleagues, our medical oncology colleagues, and our radiation oncology colleagues. So we provide the image-guided procedures, including biopsy. We also, when cancer or another finding is present in the breast that can't be felt, we need to help the surgeons find that spot when it's time for surgery. And so we do something called localization, which some of you are going to be familiar with. And I'll talk to you about a newer method that we have for doing that we think is more patient-friendly. And of course, in doing this, we really want to be thoughtful about our use of the imaging tools that we have. I'll say at the end in my summary, new is not always better, more is not always better. Maybe that's surprising coming from a radiologist, but especially in breast imaging, we really rely on evidence to guide thoughtful use of our imaging tools. So a brief reminder, what are some of the key imaging tools that we have? We, of course, have mammography, which you are no doubt familiar with. So that is an imaging exam that's acquired using low-dose x-rays of the breast, and you can see images there in the upper right that demonstrate that. One of our other 3 primary imaging tools is breast ultrasound, which of course is not using radiation, just using sound waves to characterize the sonographic properties of the breast tissue. And then we also, of course, have breast MRI, which is a really powerful tool in our breast imaging armamentarium. Very important. It uses a combination of a magnetic field, some applied radiofrequency pulses, and then at this time it does require the use of contrast, sort of loosely considered dye. And then, as I mentioned, not necessarily a method, but a big portion of what we do are the image-guided procedures. And these are minimally invasive procedures that we do in the breast imaging centers, just using local anesthetic with lidocaine like you'd get at the dentist, and typically done just through a small hole in the skin through which we can perform the biopsy and obtain a sufficient amount of tissue to be accurate and provide information about the cancer biology, which is very important. So we've got sort of 4 bins of methods, and I'm going to talk to you about a new tool or technique in each of these bins, and we'll go through these individually. But we're going to talk about mammography, for which the new tool or technique is digital breast tomosynthesis, and I'll go into that in more detail, which is a more accurate way that we have of performing digital mammography. We're also going to talk about breast ultrasound, and a newer tool or technique there is what is called automated whole breast ultrasound. So instead of imaging just a portion of the breast as we do for a diagnostic ultrasound, if we are going to screen the breast, which is a potential, there is a newer method that we can do that in a more automated way that establishes more standardized quality. In addition, we'll talk about breast MRI. Which we use both for screening and diagnostic purposes. The new and upcoming aspect of breast MRI that's going to be very important is going to be shorter exams, what is called in the literature abbreviated breast MRI. And this is going to be very important as we move towards decreasing the time that it takes to have a breast MRI. Ideally, that will come along with a decreased cost of the breast MRI, and that could mean a variety of things, including if it is sufficiently less costly, perhaps it could be a tool that instead of just being used for screening very high-risk women, perhaps could also be used for screening more intermediate-risk women. And then finally, in the image-guided procedures category, we're going to talk specifically about localizations. As I mentioned, these are done when a woman is going to surgery and has something in the breast that can't be felt, and we need to direct the surgeon to that area using imaging guidance by placing something there to use as a landmark. And we have an alternative that can really improve the experience for the patient on the day of the surgery and also can improve the experience for the surgeon on the day of surgery, which is often a good thing. So let's start with mammography. And as you know, mammography is really one of our core imaging tools. We use it for screening, and it is appropriate for screening in all women. Also a very important tool that we use in the diagnostic setting. And this new application that I'm going to talk about is digital breast tomosynthesis. I'm going to focus more on the use of DBT as its acronym is for screening. It also is useful in the diagnostic setting. And the reason that it's useful is because of its greater accuracy. So stepping back just a bit, we know that mammography remains the standard for population that is general screening, and that's because mammography definitely reduces breast cancer mortality through early detection. And even in this situation where there are different organizations with different screening mammography guidelines with respect to ages and intervals, all agree that screening mammography decreases breast cancer mortality. It's relatively low cost and relatively available, so very important, but we also know it's imperfect. It has limitations both in finding all breast cancers and also in false positives, that is, things that we end up needing to work up in some fashion that are in fact not breast cancer. And often these are caused by overlap of tissues because we're taking a picture of the breast in a standard two-dimensional way where the tissues are all overlapping, and DBT gets around this a bit. So this newer technique is digital breast tomosynthesis, or DBT. You'll also hear the word, some people will call it tomo. You'll see the word 3D out there, also particularly from the vendors. It's not technically a three-dimensional examination, so we're not supposed to call it that, but it's out there and you'll certainly see that. And this is just a modified way of doing a digital mammogram, which decreases the tissue overlap, which I just mentioned is a significant cause of both false negatives, not seeing cancers, and false positives, seeing things that actually aren't breast cancer. It's more accurate than the standard digital mammogram alone, and so it really allows us in the screening setting to screen better. That's what we all want to be doing, right? We want to find more cancers when we can, especially biologically relevant breast cancers, but not at the cost of higher false positives. In fact, we should decrease our false positives, which DBT also does. So digital breast tomosynthesis increases cancer detection by somewhere around 25 to 50%, and it decreases false positives by somewhere around 15 to 18%. And of note, even though that 15 to 18% in a relative sense is lower than that 25 to 50, if you think about it, most of the things that we recall from a screening mammogram are actually false positives. So we can make a significant impact on decreasing false positives even with that percentage that you're seeing. And as I mentioned, we're focusing mostly on screening here, but DBT also has benefits in the diagnostic setting. So what is digital breast tomosynthesis? As I said, it's a modified way of doing a digital mammogram. In terms of what the patient experiences, really it's standard with respect to the typical mammographic positioning. The time and compression is the same as well. And actually, with the newer methods, the radiation dose is the same as just a standard single mammogram. And the difference is that instead of just a straight picture, say from top to bottom, a number of low-dose images are obtained in an arc across the tissue, and then that information is processed by software to make a set of different pictures. I have some videos here. They're not going to play on this computer, so I apologize, but this is was to show a woman actually having the digital mammogram in one view, and the excursion of the arc really takes maybe 5 seconds. And then what we end up with after the information is processed is we end up with 2D-like, sort of our standard mammogram-like pictures, and then we end up with these DBT slices, and we end up a whole bunch of slices that we page through sort of like a CAT scan, if you think about that, like little bread loaf slices. And I'll show you some examples, except the videos will not run, so you'll have to use your imagination. So just an example, here's a case. These aren't going to be quite as compelling without being able to scroll through the pictures, but this was a screening mammogram performed in a 53-year-old woman. You can see she has breasts that would be on the upper 2 levels of density. We think about breast density. We know that breast density limits the sensitivity of mammography. And on these 2D images, you cannot see any finding. I think even in retrospect, I do not see it. And again, this isn't going to run, but there's actually a DBT visible cancer here in the lower inner quadrant, which was, again, completely occult. It's in this area here on the conventional imaging. So increased cancer detection. This ended up being an invasive lobular carcinoma that actually measured around 40 millimeters in size. And then another screening case in a 50-year-old patient. Her 2D mammograms, again, she has denser breasts. No definite finding here. She has dense and sort of busy breasts as well. And again, I'm not going to show up here because I can't scroll the images, but she has a mammographically 2D occult, very obvious irregular mass with spiculated margins here in the upper inner quadrant. And you get kind of a sense of it here on the diagnostic images. I know it's very hard to see. Then subsequently, as part of the diagnostic workup, worked up with ultrasound and ultimately after biopsy with breast MRI. And this was a grade 2 invasive ductal carcinoma measuring 15 millimeters. So we know that we increase cancer detection when we use this tool by around 25 to 50%. Here's another case, a 57-year-old having a screening mammogram. And in this case, her breast tissue, she is not as dense. And the finding here is this little extra tissue in the right breast. This is the right medial breast. This is more on the cleavage side. And you can see this stands out. It's not matched by something similar on the other side. It doesn't look quite the same as the tissue elsewhere in this breast. And this would be something that we would typically need to recall if we just had these 2D images, because it could be a small mass with spiculations or something we call architectural distortion. And I absolutely would have recalled this had we just had the 2D images. But again, you're going to have to take my word for it, that had we had the ability to scroll through these, what DBT allows us to do, because it decreases that tissue overlap, when we go through slice by slice, we can actually see that this is just made up of crossing overlapping tissues. It's not a confluent or discrete entity, it's just that tissue overlap. So here, DBT helped us avoid a false positive. So we're going to move on now. So very exciting tool. We're going to talk about breast ultrasound a little bit, and particularly focus on supplemental screening and a newer tool or technique that is automated whole breast ultrasound. And this is an important tool because compared to the alternative, which is the standard handheld ultrasound, which has a lot of operator variability, the use of this tool improves quality by decreasing variability and also significantly decreases the time for the examination. So for automated whole breast ultrasound, stepping back, we know that ultrasound of the whole breast is a potential for supplemental screening added to mammography for women with dense breasts. And we do know that we find with this tool cancers that were not seen with mammography, and we find about 3 additional cancers per 1,000 women who were screened, somewhat comparable to using digital breast tomosynthesis. One of the limitations for screening breast ultrasound has been the proportion of false positives. That remains a challenge, although the performance has been improving. Traditionally, the way that whole breast ultrasound would be performed was, again, this handheld technique where a sonographer or a radiologist is scanning the breast one portion at a time. But we have this newer automated technique, which, as I said, decreases the variability of the exam, so that improves the quality and consistency, and also makes the exam take less time, particularly in the setting where we have limited personnel to actually perform these studies. So this shows a little bit different. You're probably used to with ultrasound just seeing this small probe that we hold on to. In this case, this is an automated whole breast ultrasound unit, and what happens is this large device is applied with slight and standardized compression onto the breast. It has a mesh piece here, and into that a large transducer goes, and then really scans that whole portion of the breast from top to bottom, in one continuous acquisition. It is repositioned on each breast. Usually, for most women, there'll be 3 sets of pictures for each breast. But the exam time is at least 25% longer than handheld ultrasound. It takes more like 15 minutes. And also, it gives us true 3D information to review. So this is an important sort of next step in terms of performing screening breast ultrasound. Next, we'll talk briefly about breast MRI. And as I'll mention yet again, this is an incredibly important tool that we have. And the newer tool or technique that we're excited about is shorter exams. This is definitely on the horizon, not quite here yet. And as I mentioned, by decreasing the exam length, this should be associated with a decreased cost and potential to expand to broader groups if that is supported by the evidence. So we know that breast MRI is the most sensitive test that we have for finding breast cancer and characterizing it, determining how much of the breast is involved, either initially or potentially after the increasingly used neoadjuvant or before surgery systemic therapy. It is the most sensitive test across a spectrum of settings, and that includes high-risk screening, so women who are at particularly elevated high-risk, that's a bit redundant, particularly high-risk categories or levels are recommended to have breast MRI as a supplemental test in addition to mammography. It's also a test that's important, or can be, when we are assessing the extent of disease in a woman with newly diagnosed breast cancer, and as I alluded to, can be useful in assessing response during or after this neoadjuvant or before surgery systemic therapy. But one challenge that we have is that the current clinical breast MRI examination length is really around 20 to 25 minutes, and that's 20 minutes is a pretty concise examination. And in addition, the current breast MRI protocols require that we use this gadolinium injected material, which is the contrast agent for breast MRI. But we have some very promising initial results for breast MRI used in the screening setting that we can potentially achieve the same diagnostic accuracy but with a much shorter examination. And in the initial studies, which are performed at single institutions, this could be achieved certainly with a duration of less than or equal to 10 minutes of acquisition time. So that's half, at least, of the time that it currently takes to do breast MRI. And this is such an important and exciting area that there's a large multi-center trial that's currently ongoing investigating this actually in intermediate risk women, and that's being done as part of the ECOG Akron network. And then in addition, further down the road, we do have some early studies that suggest maybe we can get to the point where we actually don't have to give gadolinium. Wouldn't that be amazing? We could use some of these other alternative sequences that we have in breast MRI that don't take a lot of time and potentially have sufficient accuracy to not need to give contrast for breast MRI. Certainly further research into that is warranted. So we're further ahead in thinking about shorter or abbreviated acquisitions, a little bit further behind, but still very focused on non-contrast breast MRI studies for screening. And then finally, I'll wrap up by talking about image-guided procedures and talking about localization when we need to do that for surgery. And the newer technique here is a wireless localization, which can improve the patient experience on the day of surgery. So we know that when it is necessary to remove a non-palpable or can't be felt in the breast finding, then we need to provide some imaging guidance to localize that area so that we can guide the surgeon to the correct area. And traditionally, and many of you are familiar with this, what this is required is that we place one or more wires into the breast actually on the morning of surgery. And this creates a lot of challenges. It creates scheduling challenges for the patients. It creates scheduling challenges for the surgeons who'd love to do the patients even earlier in the day, but they have to wait around for us radiologists to actually put the wire in, or wires in. It makes for a very long day for the patients, for them to have to come in super early and get this done and not have been able to eat or drink or have their normal coffee or tea. That's, it's a long day. And in addition, although it's not the worst thing, but at the end of the procedure, the patient is left with wires that are coming through the skin. Now we of course bandage these up and cover them, but if there's a better alternative, we should be pursuing that. So the alternative to that is wireless localization, and there are several new wireless methods. They all have the same concept, that you place an alternative small marker into the breast, typically up to 30 days before the actual surgery, and in doing so, the patient can come in, the woman can come in at any point in that 30 days before, on her own schedule. It separates the putting in the localization device from the day of surgery. It really decompresses that day. Also, there is no wire extending from the skin because all you're putting in is this small marker actually at the site. So I'll show you just an example of what that can look like. So these are some images from a mammogram from a patient who had a biopsy-proven cancer, which is at this site. Very hard to see the cancer itself as a mass here, but it's this little sort of stoplight-shaped clip. And here's the clip here, and you get a little bit more of a sense of a mass. So this was the mammogram that was done after the biopsy with a marker clip placed. That's a very important thing that we all need to do during image-guided procedures. And then when it was known that it was malignant and she needed to go to surgery to have it removed, instead of putting in a wire, what we did is we put in this small, this is a particular option for these wireless localizations. This is just a little reflector in the breast, which is a slightly bigger metallic piece. We put this in under ultrasound guidance because we could see the area with ultrasound, and then we do a mammogram as we finish up to show us and show the surgeons. Here is that little reflector, it's right next to the marker clip. Here is that little reflector, it's right next to the marker clip. And this particular device relies on this little probe that uses a combination of infrared light and electromagnetic waves, and the probe both sends and then the reflector reflects the energy, and it's detected by the probe. So the surgeon uses this. They walk over the breast until they find that point at which they get an audible signal to detect this, and then they're able to know that the area is just below this, and the newer consoles that the surgeons have actually give them depth information as well. So they'll say it's here and it's 3.5 centimeters deep. So this is super helpful, and then the surgeon can then just go into that area, remove the tissue. We'll take a specimen radiograph, which is what this is, to show that the proper area was removed. So this is just one of the examples, this sort of EM reflector. There are alternatives, including radioactive seed localization, which is really challenging here in California to get started. And there's also an alternative magnetic device, but they all have the same concept. How can we allow women to come in before the day of surgery so that we can then disarticulate or separate that from the surgery day? So in summary, I know it's been a little bit of a whirlwind tour. I got excited about telling you about a number of different things, and there have been these several recent advances in breast imaging methods. And of course, I'm mentioning these to you because they're important, but also because these are either now or will very shortly be available at Stanford over on the Palo Alto side, but also here at ValleyCare. So digital breast tomosynthesis, you should just have gotten the 3rd unit put in, or it's being put in next week-ish. Okay, that's great. Automated whole breast ultrasound, you do have a unit here. We're going to ramp up the program a little bit more in a thoughtful way. And then this more flexible localization, such as using this reflector device that is in discussions currently with the radiologists and surgeons, and there's a lot of enthusiasm for that. And then on the horizon would be shorter breast MRI examinations, and that's something across the nation and the world that we're all interested in doing for women. So my last slide is to emphasize that new and or more is not always better, right? And we have to remain true to that concept. We really want to be using tools and techniques that provide value and provide a better patient care and or experience. And the things that I have talked about to you tonight, I do feel really improve the patient care and outcomes, or the care and outcomes of patients. either with or combined by detection of breast cancer, more detection, exclusion of breast cancer, equally important. Shorter exams, we talked about that for both automated whole breast ultrasound and for breast MRI, and overall just better patient experiences such as these wireless localization. And I will say that we really look forward to standing on the shoulders of giants here and serving this community for breast care with compassion and science. So I thank you for your attention.
Thank you, Dr. Martini. It's with great privilege, pride, and honor that I introduce Dr. George Sledge. He's a professor of medicine and chief of medical oncology at Stanford University School of Medicine. Dr. Sledge specializes in the study of treatment of breast cancer. Dr. Sledge's research focuses on novel biologic treatments for breast cancer, particularly the development of anti-angiogenic therapies. He has published numerous articles in medical journals about breast cancer and chaired several nationwide clinical trials, including the first study on the use of paclitaxel or Taxol in treating advanced breast cancer. So this is just a very small snapshot into his extensive legacy. It's with great pride that we welcome Dr. Sledge.
Thank you, Rishi, and thank you ever so much for inviting me tonight. It's a genuine delight to be here. It is rare as a speaker that one gets a glass of Chardonnay before one speaks, and that's probably a good thing, actually. So what I'd like to do tonight is to spend a few minutes telling you how medical oncologists think about breast cancer. Because it's very easy to get caught up in the jargon, but in fact, when you get right down to it, despite the fact that I'm going to bore you with a lot of really awful figures and graphs, a lot of this is pretty straightforward. And once you understand it, you have a pretty good idea of how to interact with the medical oncologist and some idea of what they're going to recommend to you. So some disclosures here. So what am I going to talk about tonight? First, I'm going to tell you a little bit about thinking about breast cancer not as a single disease, but rather as a family of diseases. Then I'm going to talk to you about the members of that family. By the way, this is a really dysfunctional family, okay? All right. The first targeted therapy for all of cancer, estrogen receptor-positive disease. A later targeted therapy, what's called HER2-positive breast cancer. And then finally, what's known as triple-negative breast cancer, which represents a major continuing challenge. Now, let's go back about 20 years ago. About 20 years ago at Stanford, a group of laboratory researchers took a bunch of breast cancers and did a genomic analysis of these tumors. They basically sliced and diced up a bunch of breast cancers. They looked at what made up the molecular characteristics of the cancers, and then they asked the computer, and the computer, by the way, knows nothing about breast cancer. They asked the computer to lump things together. And when you do that, what you find out is that breast cancer isn't a single disease, but at a genomic level, at the level of the DNA, it's actually several different diseases. And these are diseases that have been given names like luminal A, luminal B, basal-like, ERB2 positive, and even one called normal breast-like. I'm not quite sure what that means, but it's a cancer, okay? And when you get right down to it, if you look at these match up pretty well with some things that we already knew about breast cancer. And that is to say that if you look at breast cancer, there are breast cancers that are driven by estrogen. These are cancers that are positive for something called estrogen receptor. There are cancers that are driven by a growth factor receptor on the surface of the cancer called HER2. And then there's a third group of cancers that are variously called triple negative or basaloid or estrogen receptor negative breast cancers. And when you look at these are roughly the proportions in which we actually see the cancers in patients with breast cancer. But the important lesson, and the lesson that's absolutely changed how we practice breast cancer over the years is that breast cancer is a family of diseases, not one disease. And realizing that had a liberating, incredibly powerful effect in terms of how we approach the disease. Okay? So let's start off with estrogen receptor-positive disease, okay, because this is the most common type of breast cancer, and even today is the cancer that kills the most women with breast cancer, so it's still very, very important, even though we have a lot of treatments for it. Now, estrogen is female sex hormone. It's made in the ovaries in a premenopausal woman. After the menopause, you'll be happy to hear it's made in body fat, okay? All right? I hope you didn't have too much to eat back there, okay? All right? But what happens in a breast cancer cell is that if you have an estrogen receptor, think of this as a little catcher's mitt inside the breast cancer cell, and you've got some estrogen floating around in the blood, the estrogen crosses into the cancer cell, it hooks up with that estrogen receptor, the catcher's mitt, inside the breast cancer cell, and that leads to a whole chain of events that results in the cancer growing, dividing, and spreading. So think of estrogen as being fertilizer if you have an estrogen receptor-positive breast cancer, and you're probably not too far off. Now, this was recognized as early as the 1960s, and indeed there was data going back over 100 years ago that said that if you took out the ovaries from a woman with breast cancer, it could shrink the breast cancer. But it was only with the recognition of the estrogen receptor that we can actually identify which women had tumors that were driven by this very potent hormone. And this led to the development of a number of agents to target estrogen-sensitive breast cancer. The first of these was a drug called Tamoxifen. And I will say, by way of aging myself, that I gave Tamoxifen for the very first time in the year that it came out, which was 1978. I was an intern that year. I remember it very well. In fact, still remember the patient I treated. But if you look at what happens when we give Tamoxifen to a woman who has an estrogen-sensitive breast cancer, an early-stage disease, by early stage I mean disease that is not widely metastasized, what we know with now very long follow-up, in this figure, 15 years of follow-up, is that if we give a woman Tamoxifen, we lower her chance of dying of breast cancer with 15 years of follow-up by around 10%. Significant reduction, though not as far as we'd like to go. And this resulted in Tamoxifen and drugs like it becoming the standard of care for women for early stage breast cancer. We'd already been using it for advanced stage breast cancer for many years. And what we found out is that if you give this for many years, and many years is somewhere between 5 and 10 years currently, we get some pretty impressive benefit, though again, not as perfect as we'd like. Now, why is that? Why doesn't Tamoxifen work for everyone who has estrogen-sensitive breast cancer? Well, part of the reason, of course, is that some women don't like the side effects and they throw away the pills. And surprise, surprise, if you don't take a medication, it won't work, okay? But even for women who take the medication, there are many women whose tumors become resistant to Tamoxifen. The tumor starts growing again, and that eventually causes problems. And this has led investigators in the laboratory to try and explore why Tamoxifen doesn't work for everyone. Now, one of the reasons it doesn't work is something called crosstalk. Now, if we look at breast cancer cells, and indeed if we look at all of the cells that make up your body, there are lots of these receptors. I mentioned the estrogen receptor and HER2, but there's lots of receptors, things that collect signals and tell cells what to do. And many of these cells actually will talk to the estrogen receptor. And so even if you block estrogen, if you have something else talking to it, something bad may still happen, okay? So think of this as you're talking to someone and you don't want to get a signal, so you cover your ear, okay? But someone else is still talking in your other ear and you can still hear it, okay? That causes the problem. Now, this has resulted in studies to try and figure out how we might get around this crosstalk. I won't bore you with the biology of this other than to say that there's something called mTOR, which stands for Molecular Target of Rapamycin. If that helps you out in any way, I can't imagine why it would. But mTOR is a place that we can intervene and we can block this crosstalk. And when we do that for patients with advanced disease, what we see is a pretty significant improvement in how long we go before the tumor starts growing again for someone with advanced disease. And this led to the approval of a drug called Afinitor or everolimus by the FDA a few years ago. Now, the other question that we've been looking at is the question of what happens after estrogen binds to the estrogen receptor in a breast cancer cell. Because that turns out not to be the whole story. And so investigators spent a fairly long time, somewhere around 15, 20 years after we had recognized what the estrogen receptor did, trying to ask the question, why does estrogen actually make a cancer cell divide? What happens after estrogen binds to the estrogen receptor? And here's the answer, okay? So I'll leave this up for about 30 seconds. I expect you to memorize it, and there'll be a quiz before you leave tonight, okay? Now, I could, if I wanted to just absolutely bore you to tears, go through every part of the biology of this, but I don't think in those terms, and I doubt that you do, so let's try another way, okay? Think of a freight train, a coal-powered freight train. Think of coal as being estrogen. Think of the furnace that you put estrogen into as being the estrogen receptor. Okay, you with me so far? Okay, great. That's not the end of the story, right? Okay? What's the rest of the story? Well, here's the train going down the tracks, okay? For the train to go down the tracks after you've tossed the coal into the furnace, there are all sorts of gears and shafts and pistons that have to be working to actually drive the train down the track. And so if we recognize this and realize where those gears and shaft and pistons are, maybe we can throw a spanner in the works, and by doing so, increase our ability to keep the train from moving down the tracks, okay? And we can do this with a number of different drugs. These go by the lovely name of cyclin-dependent kinase 4/6 inhibitors, okay? If you ever get tired of jargon, this is a field that will make you very tired in a hurry. There's 3 of these drugs on the market. The last one just got approved about 2 weeks ago, but they've all been approved within the last year or two for patients with advanced breast cancer. I am a little bit partial to the one in the center because the trial that got this approved by the Food and Drug Administration is one that I ran, so I'm thoroughly biased here. And this is what we did. We took patients with advanced breast cancer who had estrogen-sensitive breast cancer, whose tumors had grown on a prior hormonal therapy, big problem in the advanced disease setting. And we said, if we compare what we consider a standard of care treatment in this setting, a drug called fulvestrant, to fulvestrant plus one of these drugs that is the spanner in the works drugs, what happens? And what happened was this, and that is to say that if you look at patients who just got the fulvestrant alone, on average these patients went about 9 months on fulvestrant before their tumor started growing again. If you got the fulvestrant plus the spanner in the works drug, this jumped up to about 16 months. And this trial was positive enough that this got the drug approved by the Food and Drug Administration a short while ago. I mean, and a short while ago is 2 weeks ago. So where does this leave us? Well, if you look at these curves and you're a patient with advanced breast cancer, you're still depressed. And you're still depressed because these curves don't plateau. Okay, they still go down. This doesn't represent a cure for patients with advanced breast cancer. And ultimately, when we give drugs, at the end of the day, what we would love to do would be able to cure the disease. So this drug and the other drugs like it, the CDK4/6 inhibitors, have now entered trials for patients with early stage disease with the hope that in that setting, we would actually be able to prevent patients from ever having a recurrence of their breast cancer. These trials are ongoing, and our hope is in the next few years we'll be able to announce that we've significantly reduce the number of women developing metastatic breast cancer. And so stay tuned. Invite me back in a few years and I'll tell you more. Okay? All right. So let's move on to HER2. HER2, if you love acronyms, is human epidermal growth factor receptor type 2, which is why we call it HER2. Okay? And HER2 is part of a family of receptors. Receptors are proteins that are on the, in this case, on the surface of the cancer cell. Though these receptors have a normal role. For instance, the very first of these, HER1, is found in every skin cell in your body, for instance. HER2, which we'll talk about more, is found on cells throughout the body as well. What these all have in common is that they are normal proteins in your body which are hijacked by the cancer and make the cancer more dangerous, more likely to grow, more likely to divide. And each of these receptors is present in different cancers, but it's turned out that HER2, the second of these, is important in about 15 or 20% of women with breast cancer. And in those women, the tumor makes huge amounts of HER2. The scientific description is that HER2 is amplified in these tumors. If you look at these tumors that have large amounts of HER2, these tumors grow faster. They're more likely to spread to the lymph nodes. They're more likely to spread to other parts of the body. They're more likely to kill you. And if we were to look back in the mid-1990s, when we first started looking at this in a very detailed, significant way, if you had a recurrence of your breast cancer and you had HER2-positive breast cancer, on average, you only lived about 1.5 years. This was a very, very deadly form of breast cancer. That's changed significantly at this point, but this was very bad disease. Now, we did a lot of studies looking at HER2-positive breast cancer. One of the first things we did, and this is really important as it turns out, was to be able to have pathologists actually identify HER2 in every single tumor that we look at that comes from a patient with breast cancer. Incredibly important, because if you're going to give targeted therapy for a cancer, you need to actually know where the target is, right? You need to know how much is there in the cell. And so we can do that using very, very sophisticated methods. This is something called fluorescence in situ hybridization. And by sophisticated, I mean you measure, I don't know how well this is showing for where you're sitting, but you measure the pink dots, and then you measure the blue dots, and then you divide the pink dots by the blue dots. Very sophisticated, right? Higher order mathematics, okay? As in much of stuff. But if we look at these tumors and we find that a tumor is amplified for HER2, we now know that that's a tumor that's driven by HER2, and more importantly, we know that we can target HER2. Okay? We can target it with drugs that specifically attack the HER2 molecule. These drugs are called monoclonal antibodies. And if we now move these into patients with early stage breast cancer, as was done about a decade ago, what we can see is that patients who have early stage breast cancer, who get an antibody directed against HER2, a drug called Herceptin or Trastuzumab, that this significantly lowers the risk of having the cancer come back and significantly lowers the chance of dying of HER2-positive breast cancer. Now, significantly better is not all the way. Indeed, if you look at these figures and look at 10-year follow-up, we've improved the survival by about 10% overall, but there's still many women who recur and die of breast cancer, so we still have our work cut out for us. So how do we do it? What do we do? Well, we learn more about the biology of the disease. And what turns out is that when you look, and remember I showed you that slide that had those 4 members of the family? Remember I was talking about dysfunctional families? Okay? Now there are some families where if you get a couple members of the family together, it actually gets more dysfunctional than if you're just talking to someone one-on-one. And this is true for HER2-positive breast cancer. If you take HER2 and you put it right up next to its cousin, HER3, suddenly you've got Bonnie and Clyde, okay? It's a much more aggressive cancer. Now, when we learned this, it became obvious what you should do next. You should keep them apart, okay? And we did this with another antibody called Pertuzumab. And what Pertuzumab does is it prevents hookups, okay? It's a chaperone, all right? No! Bonnie, Clyde, stay away from each other, okay? And when you do this, this has a pretty impressive effect. When you look at patients who have advanced breast cancer and who are now getting either a standard regimen with Herceptin or Trastuzumab, the first drug that came along, and compare that to getting the two antibodies together now, what you see is a pretty impressive improvement in terms of overall survival. Now, you remember how I told you back before Herceptin came along that the average survival for someone with advanced HER2-positive disease was about 1.5 years? We're now up to about 56.5 months. Okay, so this is over a period of about 15, 20 years. We've been getting a little bit better every year. And we're hoping that we're going to get better yet with newer drugs. Not there yet, but we're getting better. Now, there are other drugs that can do this as well. One of the kind of cool things that's come along in recent years is something called antibody-drug conjugates. Now, antibodies are normal proteins. Your body makes them to fight off infections. Okay? The antibodies that we use to treat breast cancer are antibodies that are made in basically big fermentation vats. I say this looking over at these beer barrels over here. And in fact, if you go to one of the companies that makes these antibodies, it looks for all the world like if you visit the Miller Brewing Company or something. Okay, they're big fermentation vats where they make these antibodies. But if we now take one of these antibodies, Herceptin, Trastuzumab, and link it to a poison, and use the antibody not by itself, not as a naked antibody, but think of it as taking a delivery truck full of poison that you now dump on the cancer cell, that's what you can do. And that's a drug that goes by the lovely name of TDM1. T is Trastuzumab, that's the antibody. DM1 is a plant poison. It's a very old drug. It was looked at back in the 1970s as a treatment for breast cancer. Turned out it was toxic as all get out. Okay, you gave it to a patient and it would rot their liver in a nanosecond. Okay, it was bad stuff. And so it was tried out and did great killing cancer cells, but unfortunately you really want the patient to be alive after you kill the cancer. Who knew, right? And what happens now is if we take it and attach it to the antibody carries it just to the cancer cell. Okay? And so instead of it causing all sorts of these side effects, basically it's pretty much just dumping the poison on the cancer cell and we're able to use it to kill the cancer cell. And that's led to the approval of this drug by the FDA. It's now a standard therapy for patients with advanced breast cancer, TDM1. So we're getting a little bit better every year at treating HER2-positive breast cancer. There's a lot of exciting stuff going on right now. We're doing at Stanford a new trial that is combining either Trastuzumab, Herceptin, or TDM1, along with a new drug that basically gooses the immune system to help attack the cancer. Trial that we've just opened up just recently. And we're hoping that we're going to get ever closer with these drugs to being able to render this formerly really dangerous form of breast cancer into something that's a whole lot less of a public health hazard. Okay, let's move on to the third member of the family of breast cancer. And these are so-called basal or basaloid or triple negative breast cancers. Now they're called triple negative because they're negative for estrogen receptor, they're negative for progesterone receptor, and they're HER2 negative. Now if you think about this is a really dumb way of describing someone, okay? I'm walking down the street and I see a red-headed woman and I'm asked to describe her. And my description is non-blonde, non-brunette, and doesn't have a beard. Okay? All right? That's a negative description, right? And so when we say triple negative, what we're doing is giving a negative description. And what we really need is a positive description. Because as I've told you, for the estrogen receptor and for HER2, we're able to intervene because we have a positive description for what's going on in the cancer. And the problem with triple-negative breast cancer has been if you will, has been the lack of a positive descriptor, okay? But what do we know about these cancers? Well, these cancers grow fast. They look ugly under the microscope. Interestingly, this group of cancers is by and large the home of tumors that are inherited, that have an inherited mutation called BRCA1 or BRCA1, the most common form of inherited breast cancer. They're very sensitive to chemotherapy, but paradoxically, they tend to have fairly poor prognosis because the chemotherapy wears out its welcome in a hurry. And we've got some evidence that some chemotherapy drugs work better than others for this cancer. I'll go into that in a minute. But the major thing we found out about these cancers is that at the level of the DNA, they can be pretty chaotic. They build up lots of mutations in the DNA, and these mutations make them very resistant to drugs that we use and allow them to grow very quickly. So what have we learned in the last few years? Well, we've learned that some drugs work better than others. There's a trial that goes by the lovely name of the TNT trial, or triple negative trial. This compared two very common chemotherapy drugs. One is a drug that damages DNA, and another is a drug that damages something else called a microtubule. And microtubules and DNA tend to be the two big things that we use when we're attacking with chemotherapy. And if you look at the results of this TNT trial, and look over this, that's not showing up on the screen, but if you look over in the third column over there, what you see is that if you have a BRCA1 or BRCA2 mutation, if you have an inherited form of breast cancer, you are far more likely to respond to the drug that damages DNA than to the chemotherapy drug that doesn't damage DNA. Okay, so this is an important clue, and one that's immediately useful therapeutically, but is also one that is going to give us some clues about how we might defeat this disease going down the road. And this gets us to something called PARP inhibition, okay? I'm really not going to go through this slide with you, okay? Because I'm going to bore you to tears. So instead, I'm going to do this, okay? All right? What is this? It's a toolkit, right? Okay? All right. And it's a pink toolkit, which I particularly like this when I saw this online, okay? All right? How many of you have done some DIY thing at home using a toolkit? Show of hands. Okay, good. All right, so you all understand PARP inhibitors, okay? I bet you didn't know that, right? Okay? Now, I don't know about you, but I'm always losing things from my toolkit, okay? I always leave some screwdriver or something somewhere and end up not being able to find it. But the nice thing about toolkits is that some of the tools sort of overlap, okay? So if I'm trying to fix things, sometimes, even though I've lost the screwdriver, there'll be something else I'll be able to use in place of a particular screwdriver, and I'll still be able to fix something. Now, this is how the body thinks, by the way. All of us, all the time, every day of our life, we are exposed to masses of carcinogens. Every time you eat a Big Mac, every time you go out in the sun, you've been exposed to a whole bunch of carcinogens. And you would all have died by about the age of 10, okay, if your body didn't have toolkits present for fixing DNA, for fixing the mutations that are caused by all the wonderful things that we eat. And if you look inside cancer cells, some cancer cells some cancer cells are George Sledge. They've lost a screwdriver. Some people would say I've lost a whole lot more than that, but no matter. They've lost a screwdriver, but the cancer cell still has other things in the toolkit that it can use to fix DNA. Now, what are the cells that have lost the screwdriver? These are the cells that have a mutation, an inherited mutation, like BRCA1 or BRCA2. Okay? So how can we use that to treat patients with cancer? Well, we throw away another part of the toolkit. Now, I may be able to fix something because I can do a workaround with something else in the toolkit, but if you throw away two of the tools in the toolkit in my fix-it kit, I probably am not going to be able to fix the damage when something is damaged inside my house. Okay? And this works out to be true in cancer cells as well. That is to say that if we look at a cancer cell that has one of these BRCA mutations, and we now toss in a drug that interferes with another fix-it-kit member, something called PARP, you now have two problems inside the cancer cell, two ways in which the cancer cell is bad at fixing itself. And it turns out that these cells are now really, really sensitive to those drugs that damage DNA. And remember, just a minute or two ago, I told you that if you have a BRCA mutation, you're much more sensitive to DNA-damaging drugs. And this has led to the question, maybe if we use these together, something that interferes with the fix-it kit along with something that damages DNA, maybe we'll do better. And we're starting to look at that in a number of clinical trials. The first one to come out in breast cancer just came out literally a couple months ago at the American Society of Clinical Oncology. If you look at a population of patients with advanced breast cancer and you compare lots of chemotherapy drugs to a drug that interferes with PARP, with the fix-it-kit enzyme, what you see is the fix-it-kit enzyme is more effective than the chemotherapy, good news, and also, as it turns out, less toxic than the chemotherapy. Okay? So this is early days. This is patients with fairly advanced cancer. This has not yet been approved by the FDA, though they're looking at it right now. We're looking to see whether or not putting these drugs into earlier stages of breast cancer is going to do even better. But again, this is a case where if we know more about the cancer, knowledge is power, and actually allows us to do more. Now, let me finish by talking about another area that I'm sure you've all heard about in recent years, and this is immuno-oncology or immunotherapy, okay? And one of the big observations in recent years has been that cancers live in neighborhoods. If you look at a cancer under the microscope, you don't just see cancer cells. You see blood vessel cells, you see connective tissue or scar tissue cells, you see immune cells, and they make up a neighborhood, okay? Now there's good neighborhoods and there's bad neighborhoods. There's neighborhoods you wouldn't want to live in, right? And the most aggressive cancers are the ones that under the microscope have the ugliest neighborhoods. We call them poorly differentiated or high-grade cancers. You may have heard that term. The question that's come up in recent years is if we look at these cancers, either under the microscope or through other ways, can we enlist the neighborhood watch to take care of the criminals, or at least to help us out in terms of taking care of the criminals? And it turns out that if we look at the immune system, and we all have immune systems, if we look at immune systems, the immune systems have on and off switches. And there's a guy named Jim Allison who's at MD Anderson who's probably going to win a Nobel Prize in the next 2 or 3 years because he's did an enormous amount in terms of identifying what these on and off switches for the immune system. A bunch of these have been identified. They all have wonderful names. OX40, CD28, CTLA4, PD1. It turns out that if you flick the switch, what you can do now is change how the immune system views the cancer. Now here's a really interesting thing. Cancer cells, one of the ways that cancer cells get around the immune system is that they develop signals on their surface. And these signals actually signal the immune system, signal what are called T cells. And when they signal the immune system, they basically tell the immune system, don't worry about me. I'm not a problem. Go away, worry about some bacteria or virus, but don't worry about me. I'm just a nice, sweet cancer cell, okay? All right? But if we now use an antibody that interferes with that cancer cell's ability to signal with the immune system, what happens? If we put in one of these blocking antibodies, well, the immune system now wakes up and it goes, oh my God, there's a cancer cell here. I should be doing something, right? Okay? And this has been one of the great discoveries in science in the last 15 or 20 years, and this has led to a revolution in therapies for many different human cancers. It's totally changed metastatic melanoma, a disease that used to kill you in about 6 months. We now have patients living for 10 years or more with metastatic melanoma. Lung cancer, by the way, you pretty much can't turn on the TV anymore without seeing an advertisement for one of these so-called checkpoint inhibitors for lung cancer, okay? Bladder cancer, head and neck cancer, Hodgkin's disease. There's a bunch of diseases now where these checkpoint inhibitors have really changed how we treat the disease. And we're now looking at this in breast cancer and seeing whether or not this will actually help us out. Now, the answer today is we're in kind of a glass half empty, glass half full sort of situation. And let me just show you a couple of really boring studies that were presented at ASCO this year. One was a trial called the Keynote Trial that looked at patients with triple-negative breast cancer and gave them one of these checkpoint inhibitors, a drug called pembrolizumab, and then looked to see how well it would work if you had an advanced breast cancer. And the answer is it doesn't work very well. Overall, all the patients who were treated on this trial, a grand total of 8 out of 170 patients had their tumor go into remission, a 4.7% response rate. Ugh, that's sad, okay? It just didn't work very well. So this is the glass half empty part of it. Now, the same drug, interestingly enough, if we use it for patients with early, recently diagnosed breast cancer, and if we combine it with chemotherapy for a woman with triple-negative breast cancer, for early-stage breast cancer, it triples the number of women who have a pathologic complete response. Now, pathologic complete response is a woman's diagnosed with breast cancer. Wendi shows us that she's got this big tumor. The surgeon says, this is too big for me to cut out. George, shrink it, and then we'll cut it out. And when we give chemotherapy to someone who has a triple-negative breast cancer, what happens is that roughly 1 time in 5, when the surgeon goes in to do the surgery, they don't find any cancer cells at all. They've killed all the cancer cells with chemotherapy in the breast and the lymph nodes. It's a pathologic complete response. Now, if you now add in the checkpoint inhibitor, and again, this is the same drug that didn't work very well for patients with advanced disease, what you see is a tripling of the percentage of patients who have a pathologic complete response. Okay, that's pretty cool. Now, I sat in the audience at the American Society of Clinical Oncology meeting in June and saw these two presented more or less back to back, and I can tell you my head was spinning around, okay? Is this the greatest thing since sliced bread, or is this a dud? And it's too early to say yet. The research is still ongoing. We'll know more in the next few years. But again, this is kind of exciting. Why might we see the difference between early stage and advanced stage disease? Well, it turns out that the T cells, the cells that attack the cancer cells, there's a lot more of them in the primary tumor, the breast tumor, than there is in distant or metastatic breast cancer. Maybe giving it with a chemotherapy makes a difference. Maybe if you've had chemotherapy in the past, and most patients with advanced disease have had chemotherapy in the past, maybe that beats up their immune system. But the honest truth is we don't know yet, and so we still have a ways to go. Is the glass half empty or half full, and is it going to fill up with further studies is a big question to ask. Nevertheless, as a medical oncologist, I'm cautiously optimistic for this area. Triple-negative breast cancer, which was an area in the past where all we had was really god-awful chemotherapy drugs that made people sick as snot and didn't work very well. We're now starting to have some new therapies that are more based around the biology of the patient's cancer, and which may actually carry us home in terms of treating these patients going forward and get us ever closer to our goal of curing the disease. And so with that, I will come to an end, and thank you all ever so much for listening so patiently to me.
Thank you, Dr. Sledge. Thank you so much. Our next speaker is actually Dr. Trejo. It's with great pride and privilege I introduce him. I get the privilege of working with him on a daily basis. He completed his residency training at Stanford and then joined faculty at the University of Southern California, where he specialized with an emphasis on stereotactic radiosurgery and stereotactic ablative radiotherapy. He is widely published as the first author in peer-reviewed journals. His research focuses in the creation of novel clinical databases as well as outcomes in the treatment of various malignancies. He's a radiation oncologist who is here from Stanford. He works actually at the Pleasanton Cancer Center, and we have the great privilege of working with him on a daily basis. Nick, welcome.
Thank you. It's great to be here. Thanks, Rishi, for inviting me. So I'm going to talk about how radiation has evolved in breast cancer. As Rishi mentioned, I finished training at Stanford. I went to USC, and where I didn't treat a single breast cancer patient for about 4 years. Then I came back to Stanford and I'm the primary medical radiation oncologist at, you can see at the Stanford Radiation Oncology in Pleasanton, the awkwardly named SROP site. We're looking for better acronyms. If anyone has any suggestions, please feel free. And so when you're in a community practice, you treat whatever walks in the door. So I'm not treating just head and neck cancer patients anymore. I'm treating common cancers, and one of the most common cancers is, unfortunately, and as you all know in this room, breast cancer. So I had to get myself up to speed on breast cancer rather quickly. And what I found is that things have changed in the time that I was down south. Radiation oncology is evolving. That's not a remarkable statement. All fields of medicine evolve. And if you wanted a general trend of how our field is evolving, we're giving shorter treatments and we're using higher doses of radiation in those shorter treatment courses. So we are as fond of acronyms in radiation oncology as any other field. And what I mean by shorter courses is what we talk about fractionation. When every practicing radiation oncologist is asked this question at some point in time when they're talking to a patient, why do I have to come here every day for 5 weeks for you to give me radiation? And the answer is that I give to all the patients is that I'm going to give you a little bit of radiation every day. I'm going to give you enough radiation to kill a cancer cell, but not enough to kill a normal cell. That's how we work. That's why we fractionate radiation. And this has been a principle of our field since we started using radiation to treat cancer, which was about 3 years after radiation was discovered. And that's actually true. In the late 19th century, Wilhelm Röntgen discovered X-rays, and we started using it to treat cancer about 3 years later, a very quick application of technology. But we realized if we give too much, we're going to hurt you. If we give just enough, we're going to kill the cancer cells, and we're not going to cause any damage to the normal cells. So what we talk about standard fractionation is giving a little bit of radiation every day. When I mention the word hypofractionation, I'm talking about giving a higher dose of radiation over less days to essentially come to the same amount. When I talk about accelerated radiation, is when I talk about accelerated partial breast irradiation, I'm talking about giving that same amount of radiation in bigger doses and compressing the time period, so giving it twice a day instead of just once a day. And then we also have a technology called radiosurgery, also referred to as SBRT, where we give a ton of radiation in one big dose. But what's changed? Why can we do this now? We never did before. Humans haven't become more resistant to radiation as time has gone by. And cancer cells and normal cells are certainly as responsive to radiation as they've always been. The reason why we can get away with this is that our technology has improved. We've gotten better at giving radiation. And when we talk about getting better at something, we're more conformal in that we can put the radiation dose exactly where we want it. So if you have a tumor, I can see the tumor, I can put the radiation dose on the tumor and not give as much radiation to the normal tissues. And we're also more accurate in that I don't have to worry about or when I'm delivering a daily dose of radiation, that I'm putting it in the wrong place. I don't have to account for that error. And one of the professors in our department, Martin Brown, who's a radiobiologist by training, said this in one of the lectures that I attended during residency. Physics always trumps biology, and that's true. Like, as the physics improves, we don't have to worry as much about the biology. If I can hit only cancer cells, I don't have to worry about causing damage to normal cells, and so I can get away with giving higher doses of radiation over a shorter time period. So let's talk about early stage breast cancer first. What does radiation do for early stage breast cancer? Two things. It improves local regional control. What do I mean by that? I mean, radiation is going to decrease the chance that the cancer comes back in the breast, and it's going to decrease the chance that you're going to need a subsequent mastectomy in the future. And so what's the benefit of that? Well, we know that over the long term, reducing the chance that the cancer comes back is going to increase the odds that you don't die of breast cancer. And that was proven by these series of papers that have been coming out every 5 or 6 years or so from a group called the Early Breast Cancer Trialists Collaborative Group. We call it the Oxford Overview. That's easier to say. And what that is just a study, a compilation of all the early studies in breast cancer looking at breast-conserving surgery or lumpectomy and radiation. And this is why when you get a lumpectomy, generally, and I'll talk about a few exceptions, radiation is included in the treatment package. Because whatever your chance of the cancer coming back is at baseline, radiation generally reduces that chance by about 2/3. And that 2/3 reduction in the cancer coming back not only prevents you from needing further surgeries in the future, but there's a small decrease in the percentage of the chance that that the cancer coming back spreads to other places and becomes incurable and causes mortality from breast cancer. Now these are big, long papers. They're hard to read. And so I'll give you the short version. I've tried to read these papers many times. I never quite got to the end of one. They're almost like a James Joyce novel or a Thomas Pynchon novel. But this is the summation of this article, these Oxford analyses. For every 4 recurrences we avoid by 10 years, we prevent 1 woman from dying from breast cancer. So that's why radiation is generally included in the lumpectomy, post-lumpectomy setting, because that's a valuable thing. So the gray is the international unit for radiation dose exposure, and that's what we talk about when we talk about prescribing radiation doses. And the standard dose of radiation given per day is about 2 gray. And for breast cancer in the post-operative setting, when we're trying to eradicate all microscopic disease, we go to about 50 gray or 60 gray. That works out to about 5 to 6 weeks of therapy. And that's been the standard for many, many years. And that's what women got in the 1970s when they had lumpectomies, and that's what women got in the 1980s when they had lumpectomies, and that's what women got in the 1990s when they had lumpectomies, and in the early parts of the 2000s, things started to change. And the reason why is because a couple of countries who have national health care systems said, we've got a lot of women with breast cancer, and we don't have that many radiation therapy machines. So we need to sort of push these things through a little bit faster. Maybe we can do this quicker now that we have the technology to deliver radiation more safely. And so 2 groups, one from Canada, one from the United Kingdom, started testing the idea of hypofractionating breast therapy, and that's condensing essentially what amounts to the same amount of radiation, although it is a slightly smaller amount when you consider everything, compared to the normal amount of radiation. And what they found is that there's no difference in either local recurrence or overall survival. Moreover, There is less acute toxicity because we're giving a smaller total dose of radiation, so there's less of the sunburn, less of the chest wall pain. These are the main acute symptoms patients experience with radiation. And even more, the great concern is that when you're giving bigger doses of radiation, you're going to cause more long-term toxicity. You're going to cause more fibrosis of the breast. You're going to cause more heart disease and left-sided cancers. You're going to cause more lung problems, but that never showed out to be the case. So there was no difference in long-term toxicity, with a caveat that the follow-up's out to about 10 years. So taking that one step further, let's condense it even more. If the main place you're going to recur in breast cancer is around the lumpectomy cavity, why are we treating the whole breast? That was what we do when we treat post-lumpectomy. We treat the whole breast. We know that in most cases, the cancer will recur around where it started, right, around the lumpectomy cavity. So how about we treat just the cavity, and how about we do it faster with bigger doses of radiation, because we can get away with that, because we're not treating the whole breast. And this is what we call accelerated partial breast irradiation. And the key components are right there in the name. We're accelerating, and we're only treating the partial breast. So who do we think is suitable for this? Like most new technologies, we start with the patients that we think are at the lowest risk of recurrence. So these are generally women who are advanced in age, have good surgical margins, they are low stage, so low risk of recurrence, generally low grade, small tumors with good margins. How do we do it? There's many ways to do it at present, and no one way has been proven to be better than the other. One way to do it is using brachytherapy, where we give the radiation from the inside out, so to speak. So we insert, at the time of surgery, we insert a balloon or a series of catheters into the cavity, and afterwards we introduce a radioactive source into a channel into that balloon or around the edges of the cavity, delivering the radiation from the inside out as opposed from the outside in. Another way to do it is to do it at the time of surgery. So these are intraoperative radiation cones that deliver radiation. The surgeon does his surgery, takes out the tumor. The cone is placed inside the cavity, and the radiation is then introduced and goes to and treats the rim of the cavity where the most likely place of recurrence is to occur. What's the downside of these techniques? They're very convenient. Because everything's sort of put in place. The downside is that you're making a decision about something before you have all the information present. So you may not know that the margins are clear by the time you're committing yourself to this course of therapy. You may not know that the sentinel lymph node is negative at the time of introducing these techniques. So you've essentially given the patient radiation before you have all your information, and that can cause complications later. Say if the patient needs to have another surgery because the margin's not clear, or if the patient needs chemotherapy afterwards. Typically we do radiation after chemotherapy, not the other way around. The reason being that chemotherapy can sometimes induce what we call radiation recall, which is a sort of a weird phenomenon where the body responds to chemotherapy by reproducing all the effects of radiation in a as yet not entirely understood mechanism. And what if there's lymph nodes positive and you wanted to treat the lymph nodes? Then you've sort of compromised that treatment by introducing this technology. So the way we do it in Pleasanton and at Stanford is by doing it after surgery, after the final pathology is done, just by using standard 3D radiation techniques, but just focusing on the cavity. And this is what it looks like. You can see this is a breast treatment plan. On the bottom is a standard whole breast where we just treat everything. And the top is where we're focusing on the cavity. And that's where the color is where you see 95% of the radiation dose applied. And this is where 50% of the radiation dose goes. And you can really see the difference when you look at it in the whole breast view and the coronal views here, that we're treating a lot less breast and a lot less lung by doing this technique. Does this work? That's the question you're probably all asking yourselves. Here's a lot of data with a lot of numbers, but I'm going to tell you what the most important number is. What's acceptable to me as a radiation oncologist for reducing local recurrence? And the number is 1% per year. If it's less than 1% per year chance of that cancer coming back, I'm happy. So all these studies that were done in Europe demonstrate, if you look at the follow-up time, 10 years, local recurrence, 6%, that's good. That's less than 1% per year. And most of these studies done with women, again, with very favorable tumors. We don't expect them to have a high recurrence rate, but those numbers are excellent. We've looked, there's 2 large ongoing studies, both in the Canada RAPID study and in the United States, NSABP B39, looking to answer this question, looking at women with very favorable characteristics and testing whether or not whole breast or accelerated partial breast are equivalent, and we don't have data for them yet. They'll be forthcoming rather soon. Stanford has been doing this for a while. They were doing it at the time I was a resident. They're still doing it. They've published their data. Their local recurrence rates at 5 years are 3.3%. So again, less than 1% per year. That's good. What's the catch? So I told you that when we hypofractionate, we saw no difference in toxicity, either acute toxicity or long-term toxicity. Early reports from the RAPID trial, looking at a nurse-assessed cosmesis of the breast, found worse cosmesis when you did accelerated partial breast irradiation. These are things like sort of retraction of the breast. We've noted that occasionally giving this high of a dose of radiation to a concentrated area can cause something we call fat necrosis, which can lead to pain in that area, which can persist for many years. So this is going to have to be weighed. The convenience of this is going to have to be weighed against the outcomes in terms of cosmesis. For some women, this may be worth it. Some women may not want to risk the adverse outcome of worse cosmesis in this setting. But again, none of the other trials from Europe demonstrated worse cosmesis with accelerated partial breast, so we have to wait until the full set of data is released before we can answer this question about whether or not it's more toxic. Why would we do this? Why? One reason is convenience. A lot of women at this time have been through a lot. They don't want to spend 6 weeks getting radiation therapy. They don't want to spend 3 weeks getting radiation therapy. They'd love to get it done in a week. If having great cosmesis and embracing a newer technology is something that you're into, this is for you because it's much faster and it's done in 5 days. The potential for reduced toxicity in other areas is also greater. We're not treating the rest of the breast, so you're not going to have a lot of later skin changes over the portions of the breast that aren't involved that we see with radiation. And in most cases, we can avoid a lot of lung. That can reduce the chance of radiation-induced pneumonitis, which is kind of like a pneumonia that we cause from radiation. It can reduce the risk of secondary lung cancers that are caused by radiation. On the left-sided cancers, we're pretty good about staying off the heart, but the potential is there to reduce the risk of cardiac-related problems later on in life by doing just the partial breast radiation. Another thing that's becoming more and more important is the cost of this. It's more cost-effective to do shorter courses of radiation. We know this. Everybody knows this. This is a study that looked at the not just the insurance costs of radiation, but the cost to you, the patient, in terms of time and transport to a radiation facility. And if you look at whole breast in the bottom here in the middle, it's with a boost, it's about $11,000, whereas if you look at an accelerated partial breast, it's about $7,000 total cost. So significant cost saving, something that's becoming more and more important to all of us as we look to the future. The caveat underlying all these things, whole breast radiation is tried and true. We have 20 years of follow-up demonstrating it reduces the risk of local recurrence, improves your survival. Hypofractionation's only been around for about 10 years. That's long enough, I think, for most people. But some of our more stringent doctors would say we need more follow-up in terms of breast cancer, and APBI has only been around for 5 years in terms of the reported outcomes. What's more convenient than less radiation? No radiation. So for elderly patients, a couple of large trials, again, originating, not surprisingly, from Canada and the United Kingdom, looked at omitting radiation, just doing hormonal therapy for women whose risk of cancer is very low anyway. These two studies took women who were 65 and older with low risk T1, T2, small tumors, all ER positive, and just gave them endocrine therapy. And gave half of them endocrine therapy, half of them got standard radiation followed by endocrine therapy. And again, not surprisingly, and it's amazing how this keeps working out, radiation always reduces the risk of the cancer coming back. So in the Canadian study, which was first, the risk at 10 years is about 9% versus 2%. Now that absolute risk is about 7%. That's pretty low. And so it's not crazy to say, let's not do radiation in these patients. And the UK trial, which has less follow-up, demonstrated almost exactly the same thing. These, again, all less than 1% per year. Either way you go, we're less than 1% per year. That's the magic number. These conversations are difficult, though. When I have a 70-year-old woman who's talking about radiation, because the original rationale is that a 70-year-old woman, when these trials started, is probably going to die of something else when she's 80 or something. And that's not necessarily the case in the population we see here, especially in California. Women are healthy. They don't have a lot of medical comorbidities. I can easily envision them living to the age of 90. And if you extrapolate these 10-year numbers out to 20 years and you double everything, then we're looking at not 9% versus 2%. We're looking at 18% versus 4%. That's 14%. So, and the radiation, I think, is gotten with the hypofractionation, the accelerated. It's less morbid. It's less time out of their, lives. So it's a hard discussion to have. Would you trade a week of your life for a 7% less chance that your cancer comes back and you need a mastectomy when you're 90? It's a difficult discussion, and it's something that I spend a lot of time talking with patients on, because it's not necessarily as cut and dried as saying, oh, you don't need radiation, you're too old. That's not necessarily the case for a lot of these patients. That being said, we're trying to do less. Because we know that radiation has risks that carry through for many years after. And so a study that's open at Stanford right now is just trying to extend this population from the 65+ year old population to a younger population. These are 50-year-old women and over who have very low risk cancers, and looking and seeing what happens if they opt out of radiation and just choose endocrine therapy. And we'll see what happens. These are women who are expected to live, 20+ years. So it's an interesting trial. Oops. Okay, so very quickly, so the trend in early stage breast cancer for me, what happened between 2011 and the time I started treating breast cancer again, is that we're doing less radiation for women with early stage breast cancer. The opposite thing has almost happened with women with more advanced stage breast cancer. My training and residency is that when women who had mastectomies, who gets radiation afterwards? Women who have large tumors greater than 5 centimeters, more than 4 involved lymph nodes. We never treated the internal mammary nodes, which are the nodes along the central part of the sternum. And what I knew is that all these things were sort of controversial. So given a timeline here, a timeline of what's happened in breast cancer research along with my timeline, these are some studies I'm going to talk about that have sort of changed this for me if not for a lot of people in breast cancer treatment. The first two trials are surgical trials. So the standard of care was if you had surgery and your sentinel lymph node was positive, you immediately had a full axillary lymph node dissection. These two trials, ACOZOG Z11 and AMAROS, changed that paradigm. So they looked at women who had sentinel lymph nodes who were positive, and they didn't do axillary lymph node dissections, and then went on to radiation. And both of these trials found that there was no difference in outcome between doing a full axillary lymph node dissection and just proceeding with radiation. Moreover, the risk of lymphedema, as you might expect and has made sense, was less when you omitted the axillary lymph node dissection. This is a study from the Netherlands looking at the rates of axillary lymph node dissection over the years 2011 to 2015. There's been a drastic reduction in both the lumpectomy setting and the mastectomy setting in the rates of axillary lymph node dissection. They've decreased from about 80% to about 20%. I don't have the numbers for the United States. I would surmise that there's a similar trend downwards, though probably not as drastic, as we are generally slower to adapt findings of large trials into our practice, and I'll get to that a little bit later. Our friends from Oxford also publish a meta-analysis on post-mastectomy radiation, and one was published in 2014. These comprise 22 trials looking at 8,000 plus women and looking at the effect of post-mastectomy radiation. It was never controversial whether women with 4 or more nodes needed radiation. They always did. Women who didn't have axillary nodes never needed radiation. 1 to 3 nodes was always the controversial area. And what this trial showed at their longest follow-up is that there is a benefit for women with 1 to 3 lymph nodes to get radiation after mastectomy. There was not only a benefit for local regional recurrence, but there was a mortality benefit. About an 8% less risk of dying from breast cancer when you got radiation after mastectomy for 1 to 3 lymph nodes. Now, these are old trials. The chemotherapy was not as good back then. These rates of local regional recurrence of 20% are unheard of these days. They're more like 10%. Still, it's hard to ignore this data. A couple of trials from Canada and Europe, again, looking at women who were, these were radiation trials, looking at what type of radiation do we do? Do we just do the whole breast, or we treat all the lymph nodes? When I say all the lymph nodes, I mean the lymph nodes of the armpit, the axilla, the lymph nodes around the collarbone, and the internal mammary nodes, which go right down the center, which we avoided doing for so long because we didn't have a good technology to do that without putting radiation right into the lungs and heart. Now we're so much better at it that the risk, and we know exactly what the doses of the heart to the lung are, that it's become less morbid and less scary to people. And so they took patients who had 1 to 3 nodes and gave them either whole breast radiation or whole breast plus all the lymph nodes, and they looked and saw what happened. And both these trials showed similar findings: small but real, statistically significant decreases in disease-free survival and distant metastasis-free survival. So treating all the nodes reduced the chance that the cancer came back in the chest wall, breast, or the nodes, and decreased the chance that the cancer came back elsewhere. The absolute reductions in risk are really small, like 3%, 5%. But the risk of toxicity was also very small. The lymphedema risk only went up from about 5% to 8%. And the risk of radiation pneumonitis, inflammation of the lung, went from 0.2 to 1%. Both these trials showed exactly the same thing. So that kind of changed how I think about treating women with advanced stage breast cancer. So before, if a woman had a mastectomy and had a sentinel lymph node that was positive, she would have went on to get an axillary lymph node dissection. They would have taken out every lymph node they could find in the axilla. Say they found 2 out of 12 total lymph nodes. We would have said, no need for further radiation. Now, a woman with a mastectomy who had a positive sentinel lymph node biopsy would not necessarily go on to have that axillary lymph node dissection. And I would probably suggest that she have chest wall plus nodal irradiation, including her internal mammary nodes. And the reason why I'm comfortable prescribing that dose and treating that is because of our technology. And this is an example of what we do. When we started treating lung cancers with high doses of radiation, we needed a technology to be able to hit the tumor because it's moving up and down with respiration. So we developed a technology called Respiratory Gating, where we monitor a patient's breathing cycle in real time, and we tell our radiation machine, you only turn on when the patient's breathing in or breathing out, or halfway in or halfway out. We can tell the machine to turn on at any time. So now we tell all our left-sided breast cancer patients that you're going to take the deepest breath you can. And we're only going to let our machine treat you when you're taking that deep breath. And when you stop taking that deep breath, our machine's going to turn off. What does that do? Taking a deep breath pulls your heart down. Your heart's kind of attached to your diaphragm. As you breathe in, your heart pulls down into the middle of your chest, away from your chest wall, which is where we're aiming our radiation beams. You can see here very clearly that when we treat with in a deep inspiratory breath hold, the heart is much farther away from the radiation dose than it is when you're breathing normally. And the principles of radiation exposure are time, distance, and shielding, and we're getting distance here. And that's reducing the radiation dose to the heart to almost negligible levels. So we're feeling comfortable with the fact that we're not increasing the risk of cardiac events in the future by doing things like this. What are we doing next? When we treat all the nodes, we still don't hypofractionate. We don't have that data, and that's a larger field. We're not quite comfortable doing that. But there's trials looking at whether or not that's feasible or not. That's probably coming. The advent of neoadjuvant chemotherapy has sort of thrown us for a loop. We're not quite sure exactly whether or not we can apply the same rules to patients who had chemotherapy before surgery as we can to those who get it afterwards, but we're sort of puzzling it out. And there's a large trial in SABP51 looking at to see what the answer to that question is. And in the interests of gender equity for the few males I see sitting around, we are currently, as a field, having these same discussions, this almost to a T, in terms of hypofractionation, accelerated fractionation with prostate cancer as we are with breast cancer. We're just lagging a little bit behind there. This weekend, my wife sent me an article she found on NPR. This kind of gets to the purpose of my and Stanford's being out here in Pleasanton. And this sort of speaks to how slower we are in the United States in terms of adapting to data as the rest of the world is, I think. And I didn't need to even read this article. I just read the headline and I knew what they were talking about. This goes into how many women are still receiving the standard 6 weeks of radiation when I think the data is compelling that hypofractionated radiation is essentially standard of care in these women who are at low risk of recurrence in the lumpectomy setting. And you know, once the media outlets start picking up on this, you know, maybe things will change, but we're a slow evolving field, and doctors need to evolve along with the field, and we need to stay current with with the data that's out there. I'm happy to be out here in Pleasanton. I'm happy that we can bring what I feel to be Stanford level of care out into a community, especially for radiation. It's so important. It's not possible for women to drive to Palo Alto, even for 10 or 15 treatments of radiation. It's ridiculous. Stanford realizes this, and all medical centers across the country are doing this. It's important, especially in our particular field, to bring the care to the patients instead of having the patients travel ridiculous distances through terrible traffic to get to the treatment that they need. And that's what we're hoping to do here. Thank you.
Thank you, Nick. Thank you so much for that great talk. Well, so, from my end and from everybody here at the Cancer Program at Stanford Valley Care, thank you so much for attending tonight. Let's open it up for questions.
I actually have 3 questions, one for each speaker, and I'll start with Wendi. Wendi, because lobular and ductal carcinomas are different, and for me personally, my lobular was not even detected on mammogram the same month that I said and insisted that there was some lump there, and the mammogram came up negative. Do you see that there are different technologies, and maybe women have to take 2 types of mammograms to be able to get accuracy and sensitivity for both types of cancers?
Thank you. So that's a great question. We talked in great detail about some of the really nuanced tumor biology. We didn't talk, kind of stepping back, about some of those more pathologic types, like the differences between invasive lobular and invasive ductal carcinoma. So invasive lobular carcinoma we know is challenging to detect with all of our means currently. It's hard for us to find on clinical exam. It's hard for us to find on mammography and on ultrasound and on breast MRI. At this time, however, the combination of mammography and MRI is probably the most accurate, and of the tests, breast MRI does have significantly higher detection ability to find invasive lobular carcinoma, so that is an important component.
So you would see doing one technology to pick up both?
Yeah, so when we're thinking about we sort of think about in the peri-diagnostic period what would be the most appropriate tests, and obviously a diagnostic workup for a lump or something that initially showed up on imaging would include mammography, typically ultrasound, and often, especially for invasive lobular carcinomas, a breast MRI would be done in that preoperative period. Then we think about what happens after the cancer is treated, and hopefully there's been an awesome response and outcome. How do we do surveillance? The recommendations, such as from the NCCN and major organizations at this time, are certainly mammography once a year. A breast MRI for women with a personal history of treated breast cancer without other risks that would put them up into that highest category. There is certainly evidence that adds to our ability to find cancers, and we know that in women who have a second breast cancer, that improves their outcomes. So, but right now it's sort of an in-between category of insufficient evidence for or against. That said, we do screen a lot or surveil a lot of women with a personal history of breast cancer with breast MRI added to mammography.
And if I may, Dr. Sledge, for the CD4K drugs that you're testing or that you're recommending, and you did mention that you're looking to prevent recurrence by treating patients early on. I'm actually participating in a clinical trial for one of those, and I find the side effects not nice. Are there any drugs on the horizon that will reduce the side effects? And so people who want to prevent recurrence may actually take the drugs for longer?
Okay, so it's a great question. So if I can repeat the question, currently these drugs are being tested in trials. I'm having side effects. Could we be doing something better either to prevent the side effect or do something else? So first, thank you for participating in the trial. I will say women who are in clinical trials are my heroes. So you're my hero, okay? That's the only way that we move forward is to gain data from courageous women being willing to participate. So all of these, every drug has a side effect. If a doctor ever tells you, this drug has no side effects, you should immediately turn around and walk out the door, right? Okay, because they're either delusional or they're lying to you. The CDK4/6 inhibitors, I would say the side effects I hear the most commonly from my patients, or the ones I see most commonly. First, these are drugs that lower the white blood cell count. So we have to, in contrast to the hormonal therapies where we basically hand someone some pills and say come back in a few months, if someone's on a CDK4/6 inhibitor, we have to do more regular blood counts to make sure the blood count's not getting low enough to put someone at risk for infection. The other thing I hear a lot from my patients is fatigue. And I have a lot of patients who just simply feel more tired on these drugs. We don't really know what's causing the fatigue, so we don't have a really good way of intervening. It's early days yet with these drugs, so we don't really quite know what the appropriate dose is, I would say. My guess is over time what we're going to find is that for some, because we found this for every other drug, there are some patients where a smaller dose will work just as well as a larger dose, and we'll hopefully be able to avoid some of the toxicity because of that. But we're not quite there yet with me being able to tell you that.
I agree. Oops. Great. I agree. Pharmacogenomics needs to be done with the drug dosage. All right, and then Dr. Trejo, so with the advances in radiation, if you've already been treated with radiation in the past, but they didn't treat those areas that we now can do at high dose with low effects, should a woman seek radiation again to make sure that all those lymph nodes or all those areas that weren't treated before are now covered?
Okay, so the answer, so there's two, let me sort of parse your question into two different questions. One, you're suggesting that we should treat the lymph nodes that weren't treated in a previous course of radiation, and my answer to that would be probably not. That would be accruing toxicity without any known benefit, and the reason being we don't have any data to suggest that that would work. And two, in the absence of any clinically obvious disease, I wouldn't see any particular reason to. And a second question that maybe you didn't ask that maybe I kind of inferred just from the jump is that could a woman get radiation to the breast a second time? And we're often told the answer to this question is no, that cannot be done. It's done once and never again. And the answer to that question is that's not entirely true. We irradiate people twice to other areas of the body that are much more sensitive and morbid than doing it to a breast twice. And I've seen it done many times, that you can have a breast re-irradiated should you recur. Let's think of a hypothetical situation. A woman has breast cancer, has a lumpectomy. 10 years later, she recurs in the lumpectomy cavity and does not want a mastectomy. I've seen it done many times that the woman gets a second lumpectomy and then undergoes a second course of radiation. The risks are greater the second time around, but it can be done. So.
Feedback surveys on the tables, we'll collect them from there. And thank you so much, and everybody have a good night.